This is ADL number 7, Controlling Body Temperature and Infection Control. This begins on page 27 of the nursing document. We'll have a look at the nursing assessment here first. So all patients are at risk of infection while in hospital. Activate Care Plan 7A on all patients. So we'll move over to 7A. So the nursing diagnosis is the risk for infection or actual infection, and the expected outcome is that we minimise the risk of infection. The first two nursing interventions here are highlighted in yellow. We should be doing this for all our patients. Ensure the 5 moments of hand hygiene are performed. Follow standard precautions to minimise the spread of infection. And if infection suspected, use sepsis screening form and nurse patient using protective precautions. There are 2 blank spaces here if you want to write in your own interventions. So moving down back to the assessment, baseline temperature on admission can be documented here. Complete Care Plan 7B if the patient has an altered temperature or if they're at risk of an altered temperature. So we'll move over to 7B, altered temperature or risk of altered body temperature, and the expected outcome is optimal body temperature is maintained. So our nursing interventions, we do this first one for all our patients, monitor temperature, so we need to activate that. Obtain appropriate specimens for culture and sensitivity, administer antipyretic as prescribed and evaluate effectiveness. Again, we have blank spaces here if you want to write more individual interventions for your patient. Moving down along then, we have this is our catheter care bundle. So it's really important that this is completed if your patient has a catheter, because it is your catheter care bundle. Has patient a peripheral venous catheter PVC in situ? So tick either yes or no. Complete Care Plan 7C for all patients with PVC in situ. And then just a little asterisk, intervention to be activated on all patients with PVC in situ as part of cannula care bundle. So that refers to these interventions over here, which have the asterisk beside it. It tells us here as well, refer to the visual infusion phlebitis VIP score on page 28, and I'll go through that shortly. We'll move over to the rest of our care bundle or our care plan. So 7C, patient has PVC in situ, reason for PVC insertion, and that has to be documented here. The expected outcome is that we minimise the risk of infection. So our nursing interventions, carry out hand hygiene before and after all PVC procedures, assess IV insertion site and document VIP score in every shift, remove PVC if patient scores 2 or above, check PVC dressings are intact, record date and site of PVC for each cannulation on daily evaluation, assess PVC need, if not required, discuss removal with the team. And if the cannula is not in use and remains in situ, medical reason needs to be documented and sodium chloride flush needs to be prescribed and given 12 hourly. Okay, so we'll just move down along to page 28, and here is our central line assessment. So if your patient has a CVC in situ, tick yes or no, the type, the date of insertion, complete Care Plan 7D for all patients with a CVC in situ. So the reason for our CVC insertion we document here, and the last date of dressing change we can document here. Okay, so over to our care plan. 7D, patient has CVC in situ and the expected outcome, minimise risk of infection. So the nursing interventions, assess CVC need daily, if not required, discuss removal with the team, document assessment. Carry out hand hygiene before and after all CVC procedures. Access ports are labelled appropriately. Check CVC dressing is intact and has been replaced in the last 7 days. CVC hub decontamination to be carried out before each hub access. Chlorhexidine gluconate 2% in alcohol, if compatible with the CVC, to be used for cleaning the insertion site during dressing changes. Assess for blood return, patency of vein and catheter, and signs of infiltration. And we have blank spaces here to write your own interventions. So this is the VIP score. This is what we use to assess our cannula sites, and there is space on the daily evaluation to document the VIP score on every shift. So we'll go to the left here. If the IV site appears healthy when we look at it, then we're documenting a score of 0, and that means that there's no sign of phlebitis, but we need to observe the cannula. If one of the following is evident, slight pain near the IV site or slight redness near the IV site, then we document a score of 1. That indicates possible first sign of phlebitis, observe cannula. If two of the following are evident, pale near IV site, erythema, swelling, then we document a score of 2. That indicates there's an early stage of phlebitis, recite cannula. If all of the following are evident, pain along path of cannula, erythema, induration, we document a score of 3. Medium stage of phlebitis, recite cannula and consider treatment. All of the following are evident and extensive, pain along path of cannula, erythema, induration, palpable venous cord, then we document a score of 2. Advanced stage of phlebitis or start of thrombophlebitis, recite cannula and consider treatment. If all of the following are evident and extensive, pain along the path of cannula, erythema, induration, palpable venous cord or pyrexia, then we document a score of 5. And this indicates there's an advanced stage of thrombophlebitis, initiate treatment and recite cannula. So really we shouldn't be seeing scores above 2 because at this point the cannula is being recited. Okay. So the next part of controlling body temperature and infection control is on page 29. So we have a list here of some common infections: CPE, CPE contact, MRSA, VRE, C. diff, ESBL, ESBL type, so you can document that there, or other. We don't have COVID documented on this, so you may want to document that there. CPE screening required, yes or no. Please follow most up-to-date screening guidance in the infection control information folder on the desktop in each clinical area. And that is, it's in relation to CPE, but it's also in relation to COVID and all infections. Rectal swab, fecal sample reserved, yes or no. Specimens obtained, so your MSU, CSU, stool, wound swab, rectal swab, throat swab or other, and the date, we document that there. This is our MRSA screen, so if the patient answers yes to any of the below questions, they need to be screened for MRSA. Are you a resident in a nursing home or have you been in hospital in the last 6 months? Yes or no. Have you a history of MRSA? Yes or no. Date and site. Any unhealing ulcer, wound or skin conditions? Yes or no. Do you work in a healthcare facility? Yes or no. Any invasive devices such as a porthacatheter, Hitman, etc.? Yes or no. So when you're doing the screen, we do a nose swab, body swab, and that's axilla and groin. That's one swab you use for both those sites. And then depending on your patient, you may need to do these additional swabs if the patient has any non-intact skin, if they have any productive sputum, CSU if they're catheterized, or any invasive devices. And then you can document your comment here. So if the patient has any infections, we activate this care plan here, 7E. So patient is found to be colonized or infected with CPE or MRSA, C. diff or any other resistant organism. Expected outcome: patient understands the name of the resistant organism and what it is, how it is transmitted, treated and the precautions to follow. So the nursing interventions here, you read down through them and you activate whichever is relevant for your patient. Inform patient's medical team and request that the patient is informed of infection status. Discuss infection status with patient, family and provide appropriate written information. Ensure correct signage is on patient door and appropriate PPE readily available. Ensure infection status is communicated to appropriate members of the multidisciplinary team. Assign appropriate equipment to the patient. Liaise with the infection prevention and control CNS. Ask infection prevention and control CNS to speak with the patient if necessary. Ensure appropriate departments are informed of infection status prior to transfer for admission or procedure or discharge. Nurse patient in isolation and adhere to contact precautions, droplet precautions, airborne precautions. So you just tick whichever one applies. Activate MRSA care plan on page 30. Activate C. diff checklist on page 19. Patient advised to communicate infectious status information if admitted to another hospital. Complete infection control checklist for CPE as outlined in infection control folder on desktop, and you have blank spaces there to write your interventions. And as I said, the most up-to-date information on infection control and screening is available on the infection control folder on each desktop in the clinical areas. So we'll move down then to page 30. This is the MRSA care plan. So this would be activated for a patient if they are positive for MRSA. All treatment must be discussed with the team. So here you can document the patient's first MRSA result and most recent MRSA results. Has the patient a history of MRSA? Yes or no? Patient and relatives informed? And is this $ on Clinicum? So The nursing care plan. The treatment for MRSA colonisation includes treatment of both the body and nose unless otherwise indicated. The treatment must be prescribed by the medical team. So you can write the date and your initials there. So day 1, apply chlorhexidine antiseptic wash to body to intact skin daily for 5 days. Dispose of cloth after use. Hair, wash with chlorhexidine antiseptic. Wash on day 1 and day 3. Apply your Bactroban nasal ointment to anterior nares 3 times a day. Patient's clothes and bed linen change daily and put in alginate bags. Antiseptic and mupircerin must be prescribed by medical staff. So on day 2, as per day 1, but do not wash the hair. Day 3 as day 1, day 4 as day 2, day 5 as day 2, day 6 normal body wash, discontinue treatment and discard nasal and mupircerin. Day 7 normal body wash, day 8 rescreen, await results before rescreening or retreating. Await results before reswabbing or retreating and continue normal body wash until swab results are known. If negative, rescreen until 3 consecutive sets of negative results. They must be 72 hours apart. Team to advise regarding screening while patient is on antibiotics. Team to advise regarding protocol for treatment of infection, for example UTI, blood cultures, wounds. Team should follow antimicrobial prescribing guidelines and liaise with microbiologist if required. And then you can refer to the MRSA guidelines, which is available on the infection control folder on the desktop and on QPulse also.